conglomerates in Abu Dhabi, and originally had a neck surgeon, consultant at McKinsey, and then spent 10 years in the Department of Health, really helping to advance the healthcare and life sciences sector. So my question to you, Omar, as we think about the potential of technology in the healthy longevity space, is getting 120 years even desirable, and is it achievable, and what's the role of technology in that? So the question of questions, just to start with.
Thank you, Lars, and it's an absolute pleasure to be with you all today. What a magnificent event can only happen in that way. So I think the question is very important. We're talking, and if I can break it into two parts, first is the healthy, and the second is the 120. So healthy, I always say healthy and enjoyable, because sometimes we focus on the healthy part from an eating perspective, exercise perspective, and other things. But we tend to forget the enjoyable part. It might be living a healthy standards of living or a healthy life, but sometimes we forget the enjoyable part. Now, what healthy is you look at a physical well-being, a social well-being, a mental well-being. To achieve that, and there are some definitions about, well, what does that mean? What is it going to be living a healthy life? Well, if your physical well-being is there, mental well-being is there, social well-being is there, enabling you to do three things. One, just to bring it down to the basics, one is able to maintain hygiene by yourself, independently. Two is able to feed yourself independently. And third is to move from point A to point B independently. Apart from that, everything else is extra. So earning millions is extra. Going on holidays is extra. Having a big family, I'm sorry to say, is extra. But if you maintain your hygiene, you maintain your feeding, and you maintain your movement, that's the healthy part. Now, okay, so if we achieve that, and that tech and the drugs is all there, and enabling that to happen, would 120 be the one achievable? And is it achievable? Well, actually, we do have people who are living 120 today. We do have people living 130. And the question is, how do you get that to be the average for everybody? How do we get, let's say, 50% or 60% or even 90% of the population or the kids that or the newly born today to project that they are going to be 120? And what's going to be their lifetime? And what's the society is going to be like when the majority are going to be living to 120? So your retirement age, the type of jobs, the type of food, the amount of food, are all of these challenges. For myself, I would like to live 120. And I think it is achievable with the current existence of medical solutions and wellness solutions. Now, is it achievable? And I'll be looking forward to doing it. So that's my personal opinion. But it's commendable to be seen by everybody collaborating with that and doing it better.
So Omar wants to get to 120. So I believe we have different perspectives on this on the panel. My next question, therefore, to James Kirkland. James Kirkland is a Noaber Foundation Professor of Aging at Mayo Clinic, the world-famous place in Rochester. Discovered the first agent that selectively eliminates senescent cells, giving rise to also the disciplines of senolytics in many ways. Prolific award-winning science leader with over 300 publications or so, last counted, and also important, the principal investigator of the NIH Translation Geoscience Network, where that involves like 85 trials or so at this stage. So question to you, apart from the 120 years, the biology of aging, we understand better and better. The field of biomedical research into healthy longevity is advancing. How do you see the potential of drugs and biomedical interventions in this space?
Well, the field is advancing very quickly. I honestly don't know what the outcomes are going to be because things change every few days, and we'll have to see what the clinical trials ultimately show. Things can look fantastic in mice and rats, but when you get to people, everything tends to change. So there are at least 30 interventions now, classes of interventions we know that will target fundamental aging processes. And we begin aging from conception on. So Down syndrome, for example, which begins with aging of egg cells before they're even fertilized, is related to these fundamental aging processes, which are all interlinked in what we call the geraside hypothesis and the unitary theory. So these processes that underlie aging processes, which are the root cause contributors to the bulk of acute and chronic disorders, multimorbidity, and other conditions across the lifespan, are conserved across species, certainly across animals with a backbone. So some of the trials, many of the trials through the network that are underway are in humans. In fact, 90% of them. Some of them are in domestic animals, like trying to improve wool production in sheep, for example, or in domestic dogs. So what we're trying to do is do these trials in parallel rather than in series. We're looking at conditions across the lifespan, from preeclampsia, which turns out to be driven. It's a condition of pregnant women that turns out to be driven by release of senescent cells from the placenta into the mother. Down syndrome, childhood cancer survivors. There are trials going underway with St. Jude's Children's Cancer Hospitals looking at acceleration of fundamental aging processes by radiation and chemotherapy. There are several trials underway for Alzheimer's disease, one of which is about to be published and is looking promising. There are trials underway for conditions like idiopathic pulmonary fibrosis, a lung disease, a whole range of conditions. So I think one of the things that we're trying to do across these trials, irrespective of the intervention that's being used or the disease or disorder that's being treated, is to look at the same things and to look at multiple conditions, because there's something that occurs that we call multimorbidity. If you have Alzheimer's disease, you're pretty well guaranteed to get diabetes and osteoporosis and heart disease soon after, and often they occur at the same time. So instead of thinking of the old-fashioned one molecule, one target, one disease approach, we have to rethink how we approach these things, and we have to think of root cause treatments that might arguably solve all of them. This is looking to be the case in experimental animals. We don't know in people yet. Until the trials are in, I wouldn't recommend taking these drugs or interventions. I think we need to compare these interventions and compare them to lifestyle interventions, natural products, repurposed drugs, and new chemical entities. And by having a network like this across the US, we're trying to do it. There are emerging networks now in the European Union. The first steps have been taken. Britain, so there are 8 centers coming together to set up a network. There are very, very early discussions about a network being developed in the GCC between UAE and Saudi. That's very early stage. The Japanese are thinking of setting up a network, and I think as these networks develop for doing these clinical trials around the world, we need to harmonize things. So we use the same wearable devices, the same things like skin readers, the same blood and urine testing, the same periodontal x-rays, everything across the trials, and some of the same questionnaires. So we'll probably go from serious diseases and disorders first, because we don't know what the downsides of these things will be. We'll march backwards to secondary prevention, and eventually we might start these things in healthy people. That'll take long.
Thank you very much. Maybe one question and a one-sentence answer. Is it what you're doing? Do you think of this more as trying to become 120, or more that we live our last decade in better health? What's your mind frame?
Again, I come at this, I'm a geriatrician as well as a molecular biologist. And as a geriatrician, I've never had a patient tell me they want to live longer. They want to feel better. They want to be able to think properly. They don't want to be incontinent. They want good muscle function. They want to be healthy, maybe to 95 or 100 or something like that. A lot want to continue working even, and then they just don't want to wake up one morning. There aren't many people who want to live to be 120 and feel like they're 120. So a side effect of some of these things could be an extension of lifespan. But as a physician, my main thing is, can I help the person who's sitting in front of me and their family where there's a serious problem get better? And ethically, if you've got interventions where you don't know what the downsides are, you sort of have to start there before you start giving things to healthy 30-year-olds that you'd have to study for 50 plus years and may cause serious side effects that would be morally unacceptable.
Thank you. Let's now broaden a little bit from the biomedical interventions, and I'd like to ask Aejaz, Zahid, who's a group director of innovation at PUREHEALTH, the largest integrated healthcare system in the United Arab Emirates, and also formerly executive director for innovation in the national health system in England. And also by background an entrepreneur with MIT schooling, and so it was so great to have you here. And would love to know from you, if we broaden the perspective on different technologies, what are really the technologies from your perspective that help your constituency and people to age better?
Thank you. So I see longevity medicine as, in some ways, the flip side of the same coin as preventative healthcare, and we're moving in a direction at the moment where hopefully healthcare will become a lot more personalized over time. And there's a whole range of technologies that are helping to enable that end goal to be realized. So from a preventative perspective, PUREHEALTH, we've got a very strong focus on developing technologies and introducing technologies which support and empower the populations that we serve to look after themselves better, to be able to self-manage if they're on a trajectory towards a certain condition, whether it's say diabetes, and even try to prevent in some cases. And then secondly, early intervention across the full spectrum. The longer we live, the greater the probability of us acquiring a whole host of non-communicable diseases. You're more likely to get cancer as you get older. So there's some amazing technologies on the horizon that are showing some promise in detecting cancer early. Also keeping track of various biomarkers within your body to capture and also capture how quickly you're progressing in terms of certain non-communicable diseases. So there's a whole host of technologies there, both things that people can wear now through to technologies in the environment, and then moving all across to drug development, etc. Smart home technologies, which now could incorporate Internet of Medical Things, wearable devices. We're starting to bring all of these together and through a centralized platform which could apply predictive analytics to help us gauge how someone's is progressing across those two areas. So from a prevention and personalized medicine side, there's all of these technologies, and I think pervading across the whole lot of these is, of course, artificial intelligence, predictive analytics, some new areas of AI that are emerging really fast. So yeah, I think it's quite an exciting time. In PUREHEALTH, we've started to develop a platform, a centralized platform, which enables an individual to keep track of their health, both in sickness and in health. in the future, as genomics and other technologies emerge, we'll start to incorporate those into our platform as well.
Yeah, thank you. So I think for the audience, I think the great potential across the field in terms of technology and health and longevity. I think an important question is, how much potential really is there in prevention, primary prevention, so using technology in helping individuals, and how much is it about treating those that already have a condition? So maybe starting with the first perspective, in particular with Nicole, and Nicole Sirotin, who is the CEO of the Institute for Healthier Living, an award-winning internal medicine and lifestyle medicine physician, professor at Cleveland Clinic, and a world-renowned global thought leader on precision lifestyle medicine. So personalized lifestyle medicine, so how do you see the potential of that to really reduce the risk of the disorders of aging and really optimize our health and health span?
Thank you very much for that question. And I appreciate the conversation when we think about prevention in many different stages, because prevention means you're healthy and we want to keep you healthy. Prevention also means you have diabetes and we want to prevent your diabetes from developing blindness or requiring dialysis or affecting your heart, so you need heart surgery. And so both of these are prevention. And when we think about how can we take that concept of prevention, it really is a wide spectrum. What we want to do in our next phase is to be able to say, how do we prevent this in you as an individual? And how do we identify people in the population that will require our prevention tools, whether they be at the stage where you already have disease, but you don't yet have complications from that disease, or whether that is you start from a place of health, what we consider to be health in this moment, and we prevent you from developing diabetes or heart disease. And so when we think about how we can do this now, we have screening programs, we have hospital registries, we understand where people have diseases, we have heat maps of diseases around the city. But how do we then action the next phase of personalization? And I think this is where our technology will be able to assist us. We can now understand much more about one individual human, looking at the genome, looking at how your proteins are acting, looking at the metabolites in your body, looking at your own lifestyle, your own environmental exposures, and then being able to use our AI algorithms to help us understand how do we make sense of all of that, and how do we find risks that are personalized to you, meaning how do we understand, is your risk actually more on your brain health, or is it more on your liver health, or is it more on your heart? And I think to echo what Dr. James has said, there is a pathway, a biological pathway, that also unifies a lot of these diseases. So how do we come back in that pathway to be able to find solutions for you, whether that be inflammation, if you have a problem with inflammation. Inflammation increases your risk of many different diseases, cancer, heart disease, diabetes. So let's get at that root cause with our interventions. Then, how do we do that on a personal basis? Well, at this point, we have ways to help change people's lifestyle in a personalized way, because lifestyle is the way you live your life. It's how you eat, it's how you sleep, it's how you socialize. And so how do we get people to move through behavior change? We now have technology to help with things like micro habits. How do you change the way you approach your day? And those are some digital tools and some human tools to help us move patients through actually a personalized understanding. When people understand, okay, I know my own risk in this one area, now how do I help change my life to do that? Then with the health system and the patient together, we can come up with plans that actually help move them towards that. That might be changing their lifestyle, in one area, putting them on medication, thinking about how do we do a more advanced screening or more additional screening for them if they have a high risk of a certain cancer or certain other conditions. So I think we're now at the point to be able to move into that, but we need also the health system to be able to support that from a reimbursement perspective, from a structural perspective, because the health system right now is extremely reactive, as we all know. You come in, we tell you you're sick, we try to fix it.
Thank you, Nicole. So a lot of potential to optimize health and the technologies that we already have at our disposal today. Of course, innovation also coming, but the institutional setting not always there yet, and great that you're working in that direction with the institute. So now let's shift over to really the management of chronic disease, technological enabled management of chronic disease, those that are already suffering from a condition or more. And what can one do there, especially in the primary care space? And there I'd like to go to Salman Rizvi. And Salman is the head of medical education and digital implementation in Japan, Australia, New Zealand, and emerging markets for VIATRIS, and is also co-author of a book titled The Real World Evidence in Patient-Centered Digital Era, which won a Reuters Award 2 years ago. Congratulations on that again. And so question to you really, how does it look like in the chronic disease space?
Thank you, Lars. I think the way all the panel have highlighted things from very early cutting-edge science and research, and also the way Nicole and Aejaz and Omar have highlighted the introduction overall. Just to highlight, I think we have seen, and I'm just repeating, I think it's critical that no one can do it alone, right? This is something as a holistic healthcare ecosystem, where we all need to contribute to move the needle. No one can say that we did it alone. So gone are the days when someone, be it in healthcare setting or industry or anywhere in research. So I think this intersection of intersectoral collaboration, partnership, public-private make a big difference. So what we did, Lars, is from VIATRIS and from the industry perspective, we had, and given the burden of disease on chronic diseases, we came up with an idea of, as our commitment for primary care physicians, because these are like the first line of defense, as we talk about, right? No matter what we do, if this is not equipped with the right tools, we'll be gap. So from that perspective, that led to that educational unmet need, led to a partnership with American College of Cardiology. Also, we partnered with American Diabetic Association, World Psychiatric Association, World Heart Foundation, and also with Chronic Disease Alliance, which is called NCD Alliance. So what we did, what was the objective? The objective was very simple, to come up with world-class curriculum, digital curriculum, which is accessible to everyone, wherever, whatever, in on-demand basis. So it's not we can cherry pick that we will do it for X country versus Y. So we wanted to make that access globally available everywhere. We came up with the name, thanks to American College of Cardiology. It's called NCD Academy, which is Chronic Academy. This academy is digital, globally available, accessible to everyone, every place. And right now we are very happy that all global thought leaders across the world have participated in building the curriculum. Fast forward in the last few years, around more than 25,000 physicians have completed those modules, exactly as Nicole was mentioning, around cardiovascular, mental health, for diabetes education, and mainly from the educational perspective of prevention will only happen when management will start happening and start, right? So I think this is something which we started, we are proud of it, and it has got a lot of global recognition because we are given this as more of a pure, unrestricted scientific support. We don't have any influence, direct or indirect, on the content. That's purely created by the global societies, and we continue to support and build further. So it's an ongoing thing. So I think this has already been implemented in UAE, and around 26,000 HCPs have completed it, and this is an ongoing journey, and we are upgrading it as we speak.
Yeah, thank you. Maybe one quick question, Salman. Because it's a great global technology-enabled intervention. How are you dealing with geographically specific treatment guidelines in this, or how are you?
Yeah, excellent. So what we did when all the societies are set together, we have given options of having European guidelines, American guidelines, and all the relevant guidelines. So if I'm a physician sitting in Latin America, in Mexico or in Brazil or here in UAE, I will choose based on my institution what is being followed. So I will follow accordingly. So we are not imposing any guidelines from one part of the world to another. We give all the options to the physician. They choose based on their institution, based on the way that public-private sector is working. They can choose and customize accordingly.
Thank you. So now we've heard from Nicole and Salman about the potential in prevention and also from a chronic disease perspective. Now, Omar, back to you. How do you think about actual performance enhancement, if you want, optimizing health outside, also potentially beyond just the disease burden, if you want, right?
So I like history. So one of the things, a great story from the region for the people that don't know about it, it's called Gilgamesh. So Gilgamesh epic. Gilgamesh epic is the oldest story written human being, so about 6,000 years ago. So what happened in Gilgamesh is Gilgamesh goes on a quest for immortality and arrives at the doors of the gods. And the gods talk to him back and forth and say, you deserve it, you don't deserve it, and all of that. And then eventually they give him what is commonly known as the elixir of life. They say, you wouldn't not die, but you would live a long time. And take this back to your people. And you lose it on the way, I said it, and take it. Now, if you look at the days of Gilgamesh, probably the only medical device, as you call it, was a stick you attach it to a bone that is broken. That's the highest of technology that could happen. Now, fast forward 6,000 years later, and we still in the same quest to live longer, but to live healthy. Gilgamesh realized that's all about family, lifestyle, eating well, and leaving a legacy of good things to do. But today, when we look at longevity, it's not a one solution or a pill. Unless Dr. Fagan disagrees, but it's not one pill that will enable us to live 120. Nowadays, we're looking at prevention, medtech and prevention, medtech in living well, medtech in diagnosing, medtech in treatment, and medtech in living longer. But also we're changing the term from medtech to health tech. So now I'm probably wearing about 3 health tech, right? So one is the watch, I've got also some GM, and I also got a health tech product, not many people realize, which is this one. Now this one is a performance enhancing tool, right? So my vision can go far, but with this I can go even further. I can do more things in my life than is possible without this. And it happens along the way. There's a great book by Yoel Harry for the people who goes into this. And the first one is talking about Homo sapien, where we came from, and the progression in cognitive and all of the other elements. But the second one is called Homo deus. So what it means is humans are going to shift from being a species of sapiens to a species that's closer to gods. So what we did as humans is we moved away from asking the gods to grant us immortality or asking the gods to live there. And we took it upon our hands to do it. So nowadays we've got tools that enhance performance to a degree that in the Olympics they started banning. If you remember a few years ago when the artificial leg started, the people who are regulating the sport, they started noticing that actually the gun with the artificial leg is much faster than the other ones. But they also started noticing that the suits for the swimmers is giving unfair advantage for the people who have against the people who didn't have. If you remember the this going around in the Sydney Olympics. So all of this is telling us that our performance will enable us to live healthier, and our medicines enable us to live longer. The longevity of it is all about either stopping it or basically elongating what's happening, or reversing it. And I think there are so many different fronts happening. Just to very briefly touch on what Aejaz is saying, and the colleagues are saying, so many things happening. And they are all contributing to the same thing. There is no one answer. And I hope we actually get down to that and let's help you on what we are doing today.
No, I mean, thank you for the 6,000-year arc, and I think I take that as a cue now to really, in the last round, go really into the future. But just a very brief comment. In what we've just heard, there is really a question of what is health. Is health just the absence of disease? Commonly, that's how we think about it. And what you're saying is really about functional health. How well we can function, it's an optimization of health. It is a fundamental shift how we are commonly thinking about health that's underlying that. But now, in the last round, let's really think about looking forward. What is needed to really accelerate this space overall? What are potentially some catalytic interventions that we can think about? And there, I'd like to ask the first question to Jim again, and looking again at the biomedical space, what is needed to really accelerate? There's a lot of momentum, but like if we want to think about the next decade, how can we move this space ahead even more?
Well, I think it goes beyond the biomedical space. We have to think of everything. It's sort of a merry-go-round. We need to attack everything at once, right from fueling the pipeline, which in my view is very important. It's coming up with new basic biology interventions and preclinical models, right through to regulatory support and buy-in by leaders of countries. I think Singapore, for example, is a shining example of this with what Andrew Nair, Brian Kennedy, and others have been able to do because the government led this. And I think this is happening in the GCC as well, and some other countries. So, and everything in between. So we need to think of ways of providing support for basic research that is high risk and high potential gain and is not reviewed necessarily by peer review groups who are very conservative and will only fund people to test their hypothesis after they've already proven it in their grant application. So we need to get away from that mindset. We need to get away from vertical thinking in the biomedical disciplines and thinking about only one organ system and thinking across systems. If someone's a neurologist, how can their intervention that might target fundamental aging processes affect the endocrine system or the heart? We need to have basic biologists thinking in terms of how do you translate this through the clinical studies. Should basic biological research be done under what we call good laboratory practices standards that regulators will accept so that you can write an investigational new drug application? How do you cross the valley of death between the laboratory and the first clinical studies? And there are very few people in the world who can do this with respect to fundamental aging processes. There may be 15 geriatricians in the world who are PhD molecular biologists or cell biologists. So we need to train people who can do some of these things. We need to think at the regulatory level, how do we approve the new kinds of clinical trial designs that are going to be necessary beyond the usual phase 1, 2, and 3? How do we allow designs that are based on targeting biomarkers of fundamental aging processes and seeing that way we can move to prevention a lot faster? How do we do adaptive trials where we change the intervention as we go along in the patient? We don't stick to just one intervention and combine interventions in a personalized way. How do we do case control studies where people, if they insist on taking something, and we tell them not to, we still get a sample before and after from them and with their permission and be able to study that? How do we get regulatory codes adopted? Like how do we get the ICD-11 code for impaired intrinsic capacity adopted by, for example, the American Medical Association in the US, which comes up with the codes that physicians can bill for and insurers can pay for? So all of these things have to be thought of. And if any one of them is deficient, you can stall the process. You've got to have push and pull.
A huge agenda there that you've laid out, let me just say. Nicole, from the personalized lifestyle medicine perspective, what are ways to accelerate this based on where we are? How can we move quicker?
Thank you. I agree with Dr. Kirkland's view. It has to be comprehensive. But I think one of the questions that I ask us as a society is really, what if hospitals were paid to keep you healthy, right? And right now, our incentives are actually aligned with paying only when people are sick. So if you think about how do we then move that either out of the hospital system, out of the traditional healthcare system, into a different model, we can think about aligning our incentives as a society to keep us healthy. How do we do that in a personalized lifestyle medicine way? Well, that is actually extremely comprehensive. We want the food industry to actually be producing food that keeps us healthy instead of food that makes us crave salt, sugar, and fat. We want the physical spaces around us to be encouraging us to be moving our bodies. We want quiet places to sleep, and we want places where we can have good social connections. And we want to do all of this with the goal of keeping us healthy. And I think your comment before around what does healthy mean? What does it actually mean to be healthy? Is where we can use the personalized approach to say, we know that disease is a spectrum, every single disease. It's not that you just wake up one day and you have it, right? So how do we find those waves and those patterns that are changing in your body early so that we can identify those risks and then reroute people to a healthier path?
Thank you. So now as we think about the elderly and how can we better innovate to help the elderly population? And are we set up for success there?
So I think there's a lot of innovation happening in the medical space, which is tremendous. I think we also need to expand the scope of innovation beyond just the medical as well. I think longevity is impacted by numerous factors. And so we need to think about areas such as urban design, innovation in urban design, and how we design our cities to be better prepared for an aging population. We need to think about how our communities are set up, so social innovation around communities, and that will probably vary from culture to culture. And then I think policy design, we need to think about innovation in policy design as people live longer, want to work for longer, our pensions and all of these kind of elements designed for that population. For the last 45 plus years, I've been involved in an observational study with a sample size of n equal to 1. The subject is my dad, who's about to turn 90 in the next couple of months. And if you look at him, he looks like somebody who's easily 20, 30 years younger. And I've always been, for the last few years, I've been wondering, what is the secret of what keeps him so youthful, and particularly compared to many of his contemporaries. So one of the first things I've learned is that he never retired. He practiced as a doctor well into his late 70s. And even after he hung up his stethoscope, he continued to mentor his colleagues, he's continued to write, and he chose to move to a city which is designed better, where he can keep more active. He loves walking. So many of the elements of the blue zones that many people know about, I can see in his day-to-day lifestyle exist. But I think a lot of that has to do with his environment and community. And so I think we need to expand the scope of innovation, coming back to your original question, to focus on areas beyond the medical.
Thank you. And we are running out of time, so the last question to Salman, because it's complicated, right? So therefore, we need much more health literacy for all of us, and especially beyond the experts in this room, for the population out there. how can technology help us with that? Because we need to, in order to take control and benefit from the promises of technology, we need to know more about health and what's driving it. So what can we do there?
So Lars, we went as from industry perspective and from the company as VIATRIS perspective out of our comfort zone. And we thought we see the patient journey in a holistic manner. So within patient journey, the first thing is more from health literacy and awareness. And there is a lot available in literature that even literates, when it comes to health literacy, there is a big gap. So given that, we had created something which was first of its kind of partnership. This partnership was with the Emirates Airline and VIATRIS. We came up with health literacy huge initiative which was very light-hearted, and that was part of their ICE. This is their entertainment system, which is one of the largest in terms of its offering and things. So we collaborated with them and we developed with the technical experts of Pixar, Sony, fully integrated something called Health Matters with Dr. Adam. I encourage everyone to see it's available on YouTube as well. And that has probably more than 50 episodes. And it's all around, exactly as my colleagues and panel have mentioned, around chronic disease, but in a very simplistic, light-hearted manner with a family of ill. So you will enjoy it and you will see. And the good thing is, as Lars, everyone was mentioning, the reach. Because it has to go to masses. So right now as we speak, there are more than around 43 million passengers travels with Emirates Airline. Even if we take a slice of 5% of that, that will be a good thing to start. We are not saying we are changing the world, but we are contributing to that part. And this thing is open. So we are very open to partner, collaborate with much more health authorities. And there is, stay tuned, we have much more things coming on from wearables and from health literacy perspective, where we will partner with very unconventional medtech technology and with other partners as well. So we try our best, we strive for that.
So I think it remains to be the access is what you mentioned. So you mentioned some people flying 5%, but not everybody can fly. The issue is we still, I worry of a future that the medtech and the medicine is available for the have, and the have-not will be living for the fortune. But I agree with you, at the end of the day, it's about one person at a time, one organ at a time, one cell at a time, and the solutions will follow.
Absolutely.
Thank you for mentioning this. One thing we have not discussed is the health equity dimension of all of this, right? It's obvious for all of the speakers, we have discussed it also at the sidelines, but it's a huge question as well. I take away, thank you to all you as panelists and speakers. I take away that there's tremendous potential, but we have a lot of work to do on different levels, different stakeholders to fully capture this, right? Even with their great seats in the ground, some of them are already starting to create blossoming plants, but there's a lot of work to do. And we don't have a Q&A in this format, but I encourage you on behalf of all of us here, chase us individually after the talk if you would like to continue conversation on any of this. And thank you very much.